They'll swab you and they'll streak it out in a blood agar plate and look for beta hemolytic S. aureus, right? Or S. pyrogens. If it's there, then they give you an antibiotic. If it's not, then they say, hey, it's a virus, go home and just get over it. But I used to get strep throat so bad that my tonsils would swell and I couldn't even swallow the pills. And so they kind of knew me and they'd give me my drug. All right. What else can you do? So, use the drug properly. What this means is use the drug until completion. If your doctor writes you a script for amoxicillin and he tells you to take it for 14 days, twice a day, do it. Even though after 3 or 4 days you feel fine. Why? Well, once you have to take it after taking it for 3 or 4 days, you start to feel better because you've just killed 99% of the organism. But there's still 1% left. Now, if you take the drug all the way for 14 days, chances are you'll kill that 1%. If you stop early, that 1% just grows right back. And now it's grown right back, and the reason it survived, the reason it was the 1%, is because it was already slightly resistant to the drug to begin with. So now when it grows back, it comes back with vengeance, and when you take the drug, instead of taking 4 days, now it takes 8 days for it to work. And if you do that over and over and over again, it did completely develop resistance. Okay? So it's important to take the drug until completion. Drugs should be as narrow range as possible. So we talked about if they're not narrow range, especially if you take them orally, they kill all the commensals in your gut and your patient feels like shit. And I can guarantee you once they get home and start taking those drugs and they're throwing up and pooping everywhere, the first thing they're going to do is stop taking the drug. Which means, again, the organism can grow and develop resistance. And if you know that you're going to be treating an organism that is very difficult to kill, use multiple different drugs. An example would be tuberculosis. Tuberculosis is a very difficult to kill organism and it develops resistance very quickly. So what we can do is instead of treating it with just one drug, we treat it with 3. And each drug works in a different way. One targets the cell wall, one targets DNA or RNA production, and the other one targets DNA production. Okay? What this does is it kills the organism, and it's unlikely that they're going to develop resistance because you're hitting it in 3 different ways. It's very, very difficult, if not impossible, for there to be mutations in all 3 of those different ways that allow the organism to survive. So if it develops resistance to one of the drugs, the other 2 come in and they save the day. Now, drugs aren't perfect. As we talked about, there are side effects. And as I mentioned, most of the time the side effects are associated with toxicity. And that's because they are targeting your own cells, killing cells, and that is problematic. However, drugs can also cause allergies. So if you're allergic to the drug, it can be pretty nasty, especially if you just injected someone with a really concentrated form of the drug, like penicillin. And as we talked about, they can also disrupt normal flora and cause a lot of problems, especially in the GI tract. But there are other adverse effects. One example is over here. This is what we call a drug eruption. This is an adverse effect of certain drugs where you get a really red rash and kind of this graying of the teeth. We don't fully understand what's happening here. We don't know why this is occurring. There's no toxicity. But what we do know is if you don't stop the drug, the patient will die. So it is pretty nasty. But again, it only happens with certain classes of drugs. And once you get this once, you're more likely to get it again, so we know not to treat with those drugs. Okay, so how do we determine what drug works with what bacteria? Okay? We do this by using laboratory tests called antimicrobial susceptibility. Okay? Antimicrobial susceptibility is done one of 2 ways. The easiest way is something called the disc diffusion assay, also known as the Kirby-Bauer test. This is where you take your organism, you spread it all over a plate so that it creates a lawn. Okay, so organism covering the entire plate. You then take antibiotic discs. These are little pieces of felt that have antibiotics soaked in them. And you place them on the plate and then incubate it overnight. What's happening overnight is the antibiotic is leaving the disc and diffusing through the agar. So that you have high concentrations of the antibiotic close to the disc, and low concentrations the further away you get from the disc. You then come back after you incubate it overnight, and what you'll notice are these clearings around the disc. These clearings are called zones of inhibition. This is where organism could not grow because the antibiotic killed it. If your zone of inhibition is very large, like up here, that tells me that my organism could not grow in the presence of the drug, even in very low concentrations because it's so far away from the source. This would tell me that my organism is susceptible to that antibiotic or can be killed. Conversely, you may see something that looks like this. We have a very narrow zone of inhibition. This tells me that the organism can grow in high concentrations of the drug because it's going right up to the disc, which means it's more than likely resistant. And sometimes you can get something that looks like this, and this is what we call intermediate. That essentially means we have no idea, because it's growing close, but not that close, so it could go either way. So this is great to get kind of an idea to start with, but it doesn't really tell you anything about the amount of antibiotic required. If you want to know about the amount of antibiotic required, you would use something called an E-test strip or a dilution assay. The way this works is you have a felt strip, and this strip is soaked in antibiotic, but at different concentrations. So in this case, 0.002 micrograms, all the way up to 32 micrograms. You then spread your bacteria along, like we did before, put the strip on top of them, incubate overnight, and come back. And what you look for is right where the bacteria starts to grow back up again. This tells you the minimum inhibitory concentration. This is the smallest amount of drug that still kills your microorganism. So in this case, for whatever this is, IP, you can see that 1 is right where the organism starts to grow again. That is the minimum inhibitory concentration. The lowest dose you should administer to your patient systemically. Now these work well, but they're relatively expensive. Okay? So there are cheap and cheerful ways, and that is doing something called the tube dilution assay. This is where instead of using a strip, you're using a series of tubes that you dilute your antibiotic in serially. So you start off at a high dose, and then you dilute it again and again and again and again, just like we did in our dilution test, until you get to 0, close to it. You then store it in the same amount of same amount of bacteria, into each tube, and then you let them grow overnight. And what you look for is the last tube that has organism growing in it. That is the minimum inhibitory concentration for that particular antibiotic and organism. Why do this? Well, we do this to come up with something called the Therapeutic Index. Okay? The Therapeutic Index is a ratio between the effective dose, which is what we just calculated here, okay, versus the toxic dose, which is figured out in clinical trials when they're administering the drug to patients. And the idea of the Therapeutic Index is to use something that has the highest number possible. Okay? The reason for that is it's a ratio between toxic and effective. So 50 divided by 1 equals a Therapeutic Index of 50. What that tells me is that 1 microgram is effective, 50 is toxic. So if I use 1 microgram or maybe 2 micrograms, chances are it's going to work because it's effective still, but it's not going to cause too much harm to my patient because it's way far away from the toxic dose. So the larger the therapeutic index for that drug, the less toxicity you should see with the drug during treatment. Okay? Because you have a larger spread between the effective concentration and the toxic concentration. So on the one above, you can see 5 micrograms is effective, 50 micrograms is toxic, 50 divided by 5 is 10, which means it's not nearly as good as the bottom one because I'll have to use like 6 or 7 micrograms, and that's much closer to the 50 microgram mark, which means I might get side effects because I'm getting closer to the toxic dose. All right, that's it. Any questions? All righty, have a good weekend.